Well, good morning, everyone. Thank you for coming. This is an exciting week, and it's nice that you are all able to join us first thing this morning to get the week off to a nice start. We've been talking a lot lately about the new registry, and it's very new. It's very exciting. There's been a whole lot of time and effort and energy go into creating the new registry, and we thought it would be useful to useful exercise, bring everyone together, tell them about the registry, sort of walk you through it, show you what it looks like, so that if you, in your travels, are called upon to sell it to your constituent groups, you'll know what we're talking about. I would like to welcome and introduce Dr. Ann Stevenson. Dr. Stevenson, many of you may know, is one of the CF clinic physicians at the St. Michael's Hospital Adult CF Clinic here in Toronto, and is involved in 101 things, but in fact she also, which many people may not know, she is the director of the Canadian Cystic Fibrosis Registry. Of course, we have our Denise Mack, who is the manager of the registry, and I guess I'm the token boy, and I'll think of myself with that. So when we were starting to develop this discussion today, what I was wanting to do was just sort of talk about the new registry, explain what's new about it, why it's so great, and move on from there. But in our discussions, we sort of realized that it might be useful to give a bit of background and a bit of context to the registry. So I'm going to talk a bit about the background, context, and so on. Denise is going to walk us through the new registry with screenshots and so on, so you can see what it looks like, with patient data blanked out, of course, because if you haven't signed the confidentiality waiver and you see patient data, we have to kill you. We don't want to do that. Then Dr. Stevenson is going to talk about the uses of the registry and why it's as valuable as it is. So just giving a little background, it's going to move soon, right? What goes on here? Okay, just move the slide ahead.
Yep.
Thank you. So back in the 50s, and there's going to be changes.
Yeah, of course.
Anyway, I'll tell you anyway. So back in the 1950s, there was a pediatrician in Cleveland who saw CF children.
Yep.
Okay. So there was a pediatrician who saw CF children, and he was claiming that the survival rate with his CF population was 2%. The national average at that time in the United States was 20%. Now this is all, I suppose, hearsay, but the point being, he was saying that it was 2% based on the rest of the country, which was 20%. And that's all well and good, but if there's no data, there's nothing to support that, there's nothing to substantiate, it was just sort of hearsay that he was coming up with these claims. We don't really know how that came about. So the American Foundation decided that they would give a grant to Dr. Warren Warwick, who was actually a very influential, very prominent CF physician at the time. They gave him a grant of $10,000, asking him to collect data from some of the care centers in the States. They call them care centers in the States, not clinics. I don't know why, but in any case. So they gave him $10,000. He collected data from 31 care centers and was able to prove that, in fact, yes, the group in Cleveland had a much better survival rate. Now, of course, we don't talk about survival rates or what does it say here, the mortality rates. We talk about median age of survival, but in any case, you get the point. There's a drastic difference there. When Dr. Warwick came up with the data, he did establish that, in fact, yes, the median survival was 7 times higher than any other clinic in the state. So with that data to prove it, it was able to substantiate the claim, which was kind of neat. So moving ahead. So anyway, in the 70s, the American Foundation approached the Canadian organization and said, do you want to contribute Canadian data to the registry? And absolutely, we wanted to do that. So we contributed to the database. It was now growing at this time. And in 1976, there was the first joint report from the American-Canadian experience representing data, CF clinic data from around North America. Then in 1984, oh my gosh, she's got it. There it is. Yeah, check it out. So this
I have to get it rebound because every time I open it, one of these things comes out.
It's so cool. So this was issued from the Cystic Fibrosis Foundation, 3379 Peachtree Road in Atlanta. That's where the American Foundation was at that time.
That's right.
Issued in 78, but this is a 76 report. If we can move to the next slide, it talks about. This is the table, this is the summary table, 1976 data, Canadian centers, 2,171 Canadian patients in 76. Kind of cool.
So this is Canadian.
This is the Canadian subset
Define their
of the
2100 report.
2171, that's right.
Patient.
Yeah, so we're over double that now. This report, by the way, I mean, obviously you can tell this was generated on a device called a typewriter.
Like, look at these tables. Yeah.
Your parents might remember.
Well, I was going to say that.
Oh, I remember.
Look at this. Imagine making a mistake.
I know. Tell me about it. Oh, my God.
A typewriter
Thank God for white hair.
something that the dinosaurs used to use to communicate with each other. It's got the breakdown, interestingly. So now here, and you move ahead here, and I think this is actually really cool.
Actually, if you want to go back for a second,
Sure.
it'd be interesting to know if it's similar today. 52% are male,
Male at 52, yeah.
and 47, almost 48 are females. That's pretty much the same today.
Yeah, yeah. This is really cool. So, and then I really like the next one, the survival curve, because, okay, so we've got the Canadian experience is the solid line, the American is the dotted line, and you look at, so this is median age of survival, 72 to 76, so it's a 5-year window. We always report on a 5-year window. The individual years are just a bit too inconsistent and spiky, so we round it with a 5-year window. We've got, so the median age of survival, 50%. The Canadian experience here, roughly 24. The American experience, 50%, is about 18. So that shows us two really important things right there, which I think is really interesting. That proves to us that we know that the Canadian median age of survival continues to increase, and yes, we know that it's over 50 now. So this proves that back in the 5-year window, 72 to 76, it was that. This also shows that the American experience, for whatever reason, the Americans typically have much lower survival rates, and that proves this as well. So, I mean, this graph shows us a whole lot with just a very simple, I think.
Now, the thing is that when we were Anthony and I were at the foundation, what we heard was that, oh, thank you. Would you like? They said that the reason was because in Canada we promote the high-fat diet, and in the States they're not allowed to. Do you know anything about that?
I don't know anything about that.
Isn't that something that I had understood, or maybe I misunderstood, or something along those lines?
They could use the hypothesis that we adapted the high-fat diet earlier.
Oh, is it earlier?
I think.
Okay, maybe that's the case.
And I'm going to talk about that.
You're going to talk about that?
in a little bit.
For those of you who weren't watching closely, I just managed to make Denise squeal with glee by interpreting a graph.
What's the name of this graph?
This is a survival curve, man.
What's the name of, yeah. It is good.
That's what we're doing. So all this to say that we've had this registry around, we've got data, I mean, we actually have data. We've got a few data records back to the 60s in the Canadian registry, which I think is pretty incredible. It just sort of really picks up in the 70s and gets quite robust in the 80s. But the point being, we've got data back longitudinally for decades. And I mean, some patients in there, I mean, we've tracked their entire lives statistically in the registry from start to finish. So when I first started at this organization, which Mary was here then, my title was Patient Data Registry Assistant, and my job was data entry. I entered the data into the registry that was submitted by the clinics on paper forms.
Do you have a picture of yourself when you were that?
I have a picture of him back then.
Oh, did you put it up? Oh, I'd love to see it.
He was wearing a mustache.
That's the dirtiest look I've ever
Thank you. And so, I mean, obviously a lot has changed. What hasn't changed is the clinics still submit the data, right? Just to clarify, the patients own the data. It's their data. With consent, the clinics will submit it, collect it, and submit it to the registry. And then Cystic Fibrosis Canada, we're the custodians of the data. So it's the patient's data. They consent for the clinics to submit it, and we are the custodians. So another interesting point about this is you know that we provide clinic incentive grants to all the clinics. And we don't just give them that money. We actually ask for two things in return. We ask them that in accepting a grant that they will host a site visit periodically, and also that they'll submit data to the registry, because if there isn't a little bit of an incentive there, it's very easy to forget about submitting the data. But that's also how we ensure that the registry is as robust as it is, because clinics get the money from us, so they submit the data. That's how we make that happen.
At the same time, I have to say that not very many patient associations are doing this, first of all, as far as I know. Do we have record of anybody else doing something similar to this? Because this is really, if we talk about what differentiates us from other nonprofit patient associations, I mean, this is truly one big, and it's very patient-driven, very patient-focused, and very partner-oriented. I mean, there's so many things that is wonderful about it. Sorry, am I selling you?
No, this was misbehaving.
Oh, my goodness.
That's gotta get passed around, you know.
Oh, my goodness.
To everyone calling in, Miss Inchley has lovingly shown proof of Ian.
In 1962. With a beard.
I wasn't born in 1962.
You haven't changed, your hair color is lighter now?
Lighter. Lighter. I've been lightening it, yes. Okay, so I will just finish up by saying, so moving on then, so the new registry, what's new about it is it's now, we don't submit it on paper forms anymore. It's all internet-based, so it makes it a lot easier for the clinics to submit the data. It's a lot faster once they get up to speed, I'm hoping. I think that will be the case. It's encounter-based, so there was a time that the registry, when a patient came to clinic the first time in the year, that data would be submitted to the registry and there was one record per patient per year. Now what happens is if a patient goes to clinic 6 times a year, the clinics can submit that data for 6 times, and it makes that patient's record so much more comprehensive. What else is really new about it? There's the reporting capabilities. Clinics can now create and generate their own custom ad hoc reports, and it's also now in French. En français, for the first time, our French-speaking colleagues can use the registry in their own language.
Oh, yeah, they can put it in their...
Absolutely, yes.
Excellent.
Some pages are in French, like the variables, where the variables are, and they enter it, that's in French, but not the whole.
Putting in the data is not in French.
When you log in, it's not in French. It's
No,
French pages, but only the pages where they enter their data, that's in French.
And this is the first time that there's been any French in this.
Well, that's
For
it's a good start.
Yeah.
So is our goal to eventually get to a level where it is
Full bilingual? I think we'll have to see what the clinics want. Right? If they're okay with how it is.
I mean, if they're okay with what it is right now, but I'm always very particular about that type of balance. And if we can move in that direction, that would be fantastic.
And we now are going to have the instruction manual and other documentation in French, which was never available before. So even if they can't, most of the things are numbers that they're entering, so obviously that doesn't, it's not relevant. And some of the other things where there is words that could be in French, those ones are translated, and it's a click thing, so they would click the box.
Multi-select, yeah.
Okay.
Yeah, the menus and
the selections will be in French. So it is pretty much French, I would say.
There's very little free text.
Yeah. And if they have difficulty, like, do they contact you, or like they
contact her, and she contacts me, and I contact them, and
like you help them?
Oh yeah.
Okay.
So of course. Talk to them on the phone and everything, whatever.
You call on our behalf, absolutely.
So I'll just finish off by giving a couple of, if we can advance that, just a couple of really simple uses of the registry, which we all are quite familiar with already. There was the whole, I'll come to the uses. So the registry data, we all know this, it's now published both in paper form and on the website. We've also got clinic-specific data on the website. We talked about that whole transparency issue from a couple of years back. And we also generate clinic-specific reports that are private for just the clinic, so that gives them a bit more detail that they can compare to the national average. And then, so I'll just finish off by saying, a couple of things that we're familiar with. Kaleido. The registry was useful for the Kaleido in supporting Vertex's data request and also in getting us access to this drug.
Now I'm going to be asking questions. Now, are we registering patients on Kaleido now in the data registry? Yes?
Well, they can indicate that they're taking the medication.
Yes, okay.
And then, of course, newborn screening. The registry was quite useful in supporting the clinical study that Denise is working on now and for getting the provinces up to speed.
Yeah. And on that topic, John and Angelica, Quebec, we'll have to plan a meeting around that. the new word screening.
Okay. I'll pass over to Denise, who's going to walk us through. Show us the
For sure,
screenshot.
absolutely. So I'll just talk briefly about some static screenshots that I guess none of you will ever get a chance to see. So it's a URL link now, it's completely web-based. It's CanadianCFRegistry.ca. And this is what the world will see. This is what the public sees, what you guys will all see. And it's simply a login page with a little bit of summary of what the registry is. And if clinics need to get access to the system, they come to us, sign a confidential agreement form, and then we issue them a username and password. And then they only get access to their clinic. So a nurse from St. Mike's will get access to St. Mike's patients. All right, so there's a little cumbersome here. So the first thing they'll see when they log in, which is the, I guess, a huge feature, is that they get this snapshot. We call this a dashboard. So these are four big graphs which shows the health of their clinic, right? So you have here on the top left, you have the age and gender distribution of your clinic. You have a microbiology distribution, and the bottom two, you have your nutritional status, which is BMI or BMI percentile, and then the bottom right, you have your lung function. So here's a real-time graphical snapshot of what's going on in your clinic at any given time. So if you get access to an actual patient, you come to what is called the patient profile page. So here we have key indicators related to that patient, things like date of birth, their gender, mutation of their genotype information, and this bottom part, this graph here, this lung function over time, which is a really cool visual representation of what's going on in the history of this patient. So instead of seeing just numbers over time, it's just easy to see visually how things are going. And then there are 3 data entry points, which we're talking about what's available in French. So you see here we have the patient information, which you're entering patient-specific data, such as the date of birth and location, their employment status, things like that. And then here on the right, top right, we have the annual data record. So these are yearly health metrics that we ask clinics to enter on behalf of patients. So things like clinical measurements, what medications they're taking, treatments, complications, things like that, and then finally transplant data. So if they've had a transplant, they can indicate there the transplant information. So here, I just walk through one static page of what it looks like to enter in patient information. So here is a long form. You enter there are a bunch of questions, and the clinics enter in their responses. So essentially, there are some questions that are required, things like gender and date of birth, and then other information we ask clinics to fill in as their information becomes available. All right, so what we think is the biggest change or the biggest update to the system is what Ian was mentioning before, which is the capability to do custom reporting. So previously, they enter in data, and there was no way for them to pull the data back to them without contacting us. But now they have the ability to design and build their own reports. So that means they're able to generate reports. Here you can see this is just a midway snapshot of what it looks like if they're building their own custom reports. They can generate a bar graph, which is what we call a column, line graph, a pie chart, a patient list, or even a tabular format, summary of their patient information. So for example, they want, what we get a lot is what patients have a particular mutation. For example, there's no way for them to do that on their own beforehand. Now they can. Or if you want, say, a filter on, only male patients between the ages of 20 and 25 who have CF-related diabetes. How do they do that? They can definitely do that. And then here you just say, you put in your queries, put in your filter, and then you indicate when you generate patient lists, depending on the data that you want to pull, I want to see first name, last name, and their birth date, and then you can generate all that on your own. So really neat thing for us as well is, for example, another example of what you can pull is the genotype distribution. So if you're familiar with the annual report, this is the same format as what's seen in our annual report, but this is specific to the clinic. So it's really interesting for them to be able to do it specific to their clinic and identify something that they would be interested in. So this is St. Mike's. So you see here we have the pie chart for the distribution of, I guess, the breakdown of the genotype here in the pie chart, and then the top 10 list of mutations for that clinic. And then next we have, which is really cool, is if you might be familiar with some graphs from the annual report. So now the system will generate the annual report, the national annual report, in the system, and this will make it amazing for us because the graph will be available, but they'll be available to the clinics themselves too. So that information is now freely shared amongst everybody. That's it for me. Next one, yeah.
Sorry, quick question on that. So, and you think that's in real time? So
It's completely real
at any point,
time.
like after whatever they've entered that day, those graphs can be updated based on that
Correct,
information?
correct, completely, yeah.
Okay,
Which is great, yeah.
So I just submitted a patient input submission to the new indications for Kaleido, and one of the things I put in was a graph that showed weight and FEV1 over time of when they started taking Kaleido, which was a really great demonstration of how the product works. So I saw in there that you had the graph with showing was it lung function?
Yeah, or you mean the patient, that's, yeah.
Yeah. So is that something that can be shared with us? So patients who wanted to submit in the patient input has said, well, you know, when is this due? Because I need to get this look with my clinic to get this information. So would it be something that patients can request from their clinics, or is it something that if patients tell us that they agree for us to have the information, that we can ask you?
Pull it on their behalf?
Is that something we can do for future patient input submission? What do you think?
If patients are asking for it, or
So we, I had some patients who said, I really like to contribute to the patient input submission. I need to make an appointment with my physician to be able to give you the information you require, which is my FEVs and my weight at the start of treatment and during medication. So is it something that we can ask you for?
So yeah, to bypass going to the clinic, the patient can say, we consent via Canada to pull our records on behalf of the patient to submit for these patient input submissions. Okay.
So it's data that's already in there.
Yeah.
It's data that's already in there.
So the clinic can pull
I mean,
anyway, right?
if it's their data, their own personal information, just to show the graph, it probably would be something that you would have to do,
Clean up, yeah.
and program yourself. The difficulty is that we don't have the exact dates at which they start the medication, but if the patient knew the date, then we could look at the lung function before and after, and those are more sort of specific tailored reports that could be generated, but it'd be one-offs. They're not ones that would be a standard report that we would have in the system, if you know what I mean.
Yeah. But okay, that's a good question.
Yeah. And even just sort of highlighting some of the changes, you know, I think, as Norma, you pointed out, that there aren't a lot of data registries that date back this long. I mean, this is really one of the only ones, the CF one, both in the U.S. and in Canada, that dates back to the 60s and 70s. So that's unique about it. And a lot of registries look to Cystic Fibrosis Canada and in the U.S. for how to do this. Like, you know, they've previously contacted Mary and they contact me to say, you know, I want to create an osteoporosis registry across Canada. How do I do that? Or I want to, you know, sickle cell, because people are living longer and now they're transitioning to adulthood, and we want to be able to create a database and getting information about that. Especially diseases where it's relatively small numbers, this is really, really useful, because if you have something like cardiac disease, you know, heart disease, there's so many people who have heart disease, you can just look in one little location and have a ton of people, right? But in CF and these other diseases where there's a small number of patients, the power in this is that we can look across the country and have 3,000 patients or 4,000 patients, as opposed to if we were just looking at St. Mike's, we're talking about 400 people. Well, that's a bad example, because 400 is actually quite a few. Yeah. But say we were in Hamilton, we would be talking about, you know, 100 people or 50 people at some of the clinics. And you can't really say a lot because the numbers are too small. Certainly about survival, you can't say anything about that kind of stuff. So I think that's really, really important. And when the registry started back in these days, you know, literally, you can have a look at this after. It is interesting just to see the kind of stuff that they collected. Really, it was kind of the demographics, you know, gender breakdown, birth information. Back in 1976, they didn't even collect information on lung function and nutrition. That came a little bit later in the 80s. So as the registry has evolved, we've added more and more things that we know have become important to the registry for clinics to enter information. And sometimes you don't know what's important until it happens. An example is CF-related diabetes. When the median survival was in the teens or 20s, nobody really had CF-related diabetes. Now, in adults, 50% of patients can have CF-related diabetes. So, you know, in the early days, they wouldn't have even thought of it. Then we sort of entered it in and thought, as a complication, do they have diabetes? And we had that as a variable, but there was no date of diagnosis of the CF-related diabetes within the registry. And we realized later on that that was important because we needed to know when it occurred, because certain things would be different depending on when it occurred. So we added in the date associated with that. So these things have evolved.
Now, do you look at the date that they're diagnosed, or do you look at the date in which there's, because I think of Kingston. I know the doctor.
Richard Van Wyler?
Yes, Richard was saying that he could detect that a patient or at 10 years of age was going to be developing diabetes.
Right.
So do you go that far or only at diagnosis?
It's at diagnosis. So they could meet clinical characteristics for diagnosing CF-related diabetes, and it doesn't matter if they're on therapy. I mean, we have some people who have diabetes that therapy is tricky, or they're refusing it or whatever, but they have diabetes. So the date of diagnosis is what's important. But there are different levels of diabetes. There's impaired glucose tolerance, there's all these other things. We're just sort of focusing, when a doctor has said you have diabetes, that's the date that we want. Another really good example is transplant. In the original database, there was no date, or there was no information of transplant. Of course, when transplant started, there was a little box and there was a date. So that was the transplant date. But there was no organ, because of course, someone's being transplanted with lungs, right, in CF. But now we know that there's, you know, liver lung, there's heart lung, there's bilateral lungs, like just the lungs. People are living long after transplant that they require a kidney transplant later on down the road. You know, so there's all these other things, and it became clear that we weren't tracking the right things, so we added in an organ field so that people could indicate what it was. Because prior to that, we would look at the data and see, why was someone with an FEV1 of 89% having a transplant? Well, because they had a liver transplant, not a lung transplant. But we had to go back and clean up all that data. Now it's more clear in the registry what the transplant. So those are just sort of things that have evolved over time in the registry, and I just wanted to highlight that it doesn't, all of those things don't date back to the very beginning, because things have changed as we've moved along. So this is obviously the registry report. We no longer use the typewriter. It's very, you know, looks a lot nicer. In fact, in the past, these reports, part of the problem was the clinics would spend a lot of time entering in information, and they wouldn't get anything back until like a year and a half later after they'd entered in the information, because that's how long you had to wait till the end of the year to start generating the report. It would take a long time, and they literally would have, at the Canadian Clinics meeting at the North American CF Conference, Mary Corey would come and kind of give a couple of graphs on one of those, what are they called? The overhead? Yes, the overhead thing, and you know, show a couple of graphs, and that's all clinics got. So, you know, it's, I think, a real advance that the clinics see the data and they get information back. And now they can see all these great graphs. They can use them. Clinic directors can email and say, or now they can generate their own, but they can use these for presentations. Instead of using graphs from the USCF Foundation, we really want to encourage people, when they're talking about stuff in Canada, is to use the graphs from the Canadian CF Registry. So that's been a real advance. And again, you know, this is the graph that shows basically the age of the patients on the x-axis, and on the left-hand side, the number of CF patients at each age, and for 2013. And right away, you look at this graph, and you can see that people are living into adulthood. You know, if you look at the sort of above 18, most of the bars are to the right. So people are living a lot longer. The distribution and characteristics of the patients have really changed over the years. And we have people at St. Mike's that are 60 and 70 years old who have CF. And every time I tell somebody, oh, I'm a CF doctor, they think, oh, you work at sick kids. But obviously, you know, that's not the case, because it's still very much seen as a pediatric disease, which has to be for some reasons, especially fundraising. It makes a, you know, a difference, I guess. But it is important to recognize that the adult population is bigger than the pediatric population. And in terms of fundraising, kind of trying to give that message, use that message to help fundraise, it's important to say that this is a chronic disease now, really. People are living with CS for their entire lives. It's not the same as before where, we have patients at St. Mike's that said, I didn't think I'd have to finish high school because I thought I'd be dead by then, and now I'm 45 and I have no education and no job and I'm on disability, even though my lung function is 80%. So, people are living a lot longer with complicated diseases that affect multiple organs, and that they have to manage working, having a family, doing all their therapies, staying out of the hospital, or coming into the hospital when they have young children at home or a full-time job and they're at risk for losing their job. They don't have, so there's all the depression, anxiety, the thought of a transplant. It's a different sort of mentality, but we can't forget that adults are really important in all of this and are living with a chronic illness that is really impacts their lives, especially when the therapy just to stay well can take 3 hours a day. I mean, really, when you talk to patients and say, what time did you get up this morning? And I got up at 4:30 so that I could have my masks and do my therapy and blah, blah, and get to work on time. It really makes a big difference.
So going back for a second, this is my big question. So obviously you see post 30 years where you see the drop off.
Yeah.
And I know this is a transition, and we're talking about transition and enhancing adherence. What else can be done to lift?
Well, this is really we would need to look at some other metrics like lung function and nutrition and how that does decrease over time and decreases in adults